Hello everyone, we're getting started. Today's webinar, Marketing Patient Outcomes and Elevate Your Agency Above the Competition. Just doing some last minute housekeeping, giving a couple more people a chance to get on the webinar. I'm really excited about today's webinar. It's a rather long one, but we're going to cover outcomes in 3 product service areas: private duty, hospice, and home health, skilled nursing, and therapy services. Today is a cloudy, kind of dreary day here in Middle Tennessee. So the tag team's all huddled in their office around the building. However, if you want to contact one of us, you can get to us through eric.crump@theadamgroup.com. There's my contact information. Or simply call in 1-866-232-6477. If you're having trouble getting on the webinar, you probably don't know to call it, but if you have any technical difficulties, that's the number to call. We are in Franklin, Tennessee. You can reach us through our YouTube site to look at past webinars at youtube.com/tag webinars. And as always, you can get 30 minutes of a home care coaching call by logging on to www.homecarecoachingcall.com. You can follow TAG, the company, at TAG Home Care Marketing, abbreviated MKTG, and me personally at Eric_Crump. So, we are TAG Home Care Marketing. We sponsor these free webinars, hopefully just to kind of educate you, get you motivated on trying some new things. We only handle clients that are in the home care industry, mainly skilled nursing and therapy services, private duty, and hospice. So we are a specialty marketing firm just for you guys. We have a great success record. We are Inc. 5000 7 years in a row, and we just found out that we have won it for another year. We invite you to come to Franklin, Tennessee and visit us anytime you're in the area. We're just below Nashville. Of course, we do boot camps, so a day and a half of training. We just held our last boot camp of the year last week. It was really successful, and we enjoyed it. Today I want to talk to you about finding a different pathway and starting to market benefits as opposed to superlatives. And superlatives, I mean things like compassion, empathy, loving, caring. It's very well accepted that that's what we do as home care providers. And there's 2 problems with that type of approach in sales and marketing and how to differentiate yourself. First of all, there's no way to quantify it. There's no way to wring out all the compassion you have and show a referral source or a third-party client how much compassion and love you have for your clients or your patients. And the second thing that's wrong with that is that we're calling on referral sources who care just as much as we do about the same population. And that fact is lost on a lot of people. You're calling on doctors, nurses, who have the same compassion, empathy for their patients, their clients. You're talking to family members in private duty and in palliative care sales that they have as much or more compassion and empathy for the target population as we do. So it's like, I always tell people, it's like you're dating an Italian girl and you offer to cook spaghetti for the family. Odds are they can cook the spaghetti as well or better than you can. So be careful. It doesn't work very well, this superlative marketing. However, outcome marketing, that's the direction you need to head. December's a great time. We have the holidays, and the whole industry kind of takes a marketing break and takes in local charity events and other marketing things that we do traditionally. But it's also a great time to make plans for next year, for 2012. And this webinar today should draw a picture of a whole new direction that you can take your agency. Marketing benefits as opposed to marketing superlatives. If you can quantify the reason why a third-party referral source should give you a patient or a family member should trust you to take care of a loved one, then you're more likely to close the sale. So a good rule of thumb for home health agencies to follow when dealing with clinical referral sources is, in God we trust, all others bring data. Data, you'll be amazed. When you call on physicians, they're the most data-driven professionals in the world, U.S. physicians are. Anytime you're calling on a clinical referral source, if you're not approaching them with discovery, action, outcome, you're missing the boat. You can't go, here's what we've seen about these patients, so here's what we do about it. You have to draw out, here's your expected outcome or benefit by using us over our competitors. So the Deming cycle works in home care sales. It works very well. We need to draw a tangible picture of benefit wrapped around this intangible service we provide out in the community. So marketing patient outcomes comes up. So it's understandable the demand for data is increasing not only from our payer sources, the physicians, clinicians, third-party providers, but also our referral sources, in that Medicare pays us. Our referring physicians and other referral sources need that data to validate that they're choosing the correct care provider as well. And it's true in skilled and non-skilled services. So I always say, you want to differentiate yourself, you want to stand out from the pack, publish outcome data. Publish a tangible reason why someone should choose your intangible service. Your intent to deliver should be outlined in outcomes. So to really separate yourself from the crowded pack, as service providers, we must give referral sources a solid facts-based reason to give us their clients. So this is how you become a preferred provider. Quite honestly, if you bug a referral source or a client enough, two things will happen. Either you'll drop off one or two, and we call those mercy referrals or agitation referrals, just to get rid of you. If you buy a $400 lunch, they'll give you a home health opening with a herd profit of about $400, just payback, if you're lucky, right? However, if you want to go the path of becoming a preferred provider, then you're going to have to build a fortress, a wall that your competition has to go around or over around this referral source. And the way you do it brick by brick is adding benefit to one specific patient profile at a time. So you got to draw the complete picture on how we arrive at the results that we're touting. We also must relay to our clients how we will maintain superior outcomes and deliver superior benefit. And there's ways to do that. Remember, we're, for the most part, calling on clinical referral sources in a lot of cases. They're used to outcome reporting as well as we are. We'll get into that in a second. On today's webinar, I don't want to disclude any of our service providers. In other words, I'm going to bring in private duty and hospice into this discussion as well, because there's lots of ways we can make the intangible tangible through outcomes in private duty and in hospice services. The quickest, easiest, most impactful sale probably is still reserved for skilled nursing and therapy services. We'll talk about that at the end. But it certainly applies to private duty and palliative services. Of all the care services in home care, hospice is the one that's their core niche of marketing. It is the feeling-based market. I just want to tell you, if you have branded yourself as a compassionate, empathetic agency, then great. I don't want you to go any other direction other than I want you to layer it with benefit. In other words, keep that mantle of being a compassionate, empathetic, sympathetic provider of hospice services, and on top of that, go into disease-specific arguments with referral sources. You'll get their attention. You'll make your case more concisely with these clinical referral sources doing that. So one of the great ways you can do outcomes in hospice is give them proof that referring to hospice and referring earlier in the episode, both the quality of life and longevity of life increases with palliative care patients, and we can make that argument. So here's probably our bestseller from year before last, and one of the bestsellers the last 2 years. It's our guidelines for hospice admission, where it makes the case of end-stage indicators for 16 specific and recognized end-stage indicators. And what you're doing, taking these guidelines for hospice admission booklets out to referral sources, is you're making your argument one patient profile at a time on why appropriate palliative care referrals work. So through all these diagnoses, ALS, cancer, post-stroke, dementia, failure to thrive, heart disease, HIV, Huntington's. It goes on with liver disease, lung disease, on through all 16 end-stage indicators. It also gives a lead-in to what palliative care services entail. It has a fast, quick reference guide for clinicians to use in making the hospice referral. And the great thing about getting guidelines for hospice admission booklets is it can say whatever you want it to. Remember, TAG Home Care Marketing can make you, can allow you to tell your story how you want to tell it. Everything's customized. Marketing Patient Outcomes, a 3-year study released by the National Hospice and Palliative Care Organization, revealed across several groups hospice enrollment is not significantly associated with shorter survival. So, and that message is starting to resonate. However, it's still a drum we need to beat out there in our market, and that is making a palliative care referral does not shorten one's life. In fact, for certain terminally ill patients, hospice is associated with longer survival times. Longevity of life is increased with hospice services in very specific diagnoses. So you can do a benefits of referring to hospice flyer where you draw the picture of longevity of life. You can also maintain that the hospice patient's overall quality of life. And there's a new study that the National Hospice and Palliative Care Organization is conducting now. It's a new index of quality of death index, and you may want to look into it. There's some palliative care organizations pushing that as part of their HCAP scores, if you would, the experience of the palliative care episode. But overall quality of life indicators remain stable, less depressive episodes during palliative care periods, and they're measured by valid and reliable instrumentation. You can go out to a clinician and say, don't worry about making the referral to palliative care hospice services, because for the patient, longevity of life is going to be there and quality of life is going to be there. And moreover than that, if you're worried about losing them in the big vacuous black hole called hospice, we're going to bring them back every 30 days for their chronic disease management appointments like you want scheduled. You're not going to be out. Only the patient is going to be benefited. So here's some very specific published results for life expectancy with palliative care patients. And you could do this on your flyers as well and go after, and you have a case, right, for prostate cancer patients, breast cancer, colon, pancreatic, lung cancer, even CHF. And CHF is a big difference. And across the bottom, that's the number of days on episode. And so non-hospice patients significantly less length of life versus palliative care patients. Marketing patient outcomes. So if you're wanting to do a flyer, I could help you with that. Just get on a coaching call. We could put it together ourselves. You could hit the market next week or start the new year off with a flyer that explains these benefits. Section 1 would be the Hospice Quality of Life Index. Section 2 would be a life expectancy with palliative patients, where you're actually putting on studies and graphs supporting your claim of longevity of life. Section 3 could be specific qualities of your agency. I always tell people follow the golden rule. The golden rule in home care is, guess what, guys? It's not about us. It's about them. And it's not about us one time. It's not about us every time. In other words, our referral sources, our family members, they don't care our story. Not until you get way past their story. So it's always about them. So be careful. Don't lead off with the specific qualities of your agency. You'll start sounding like every competitor you have in the market. Lead off with benefit as to why their patients or why their specific doctor's office or agency would benefit by giving you the referral. It's always a better pitch. And then in Section 4, you would give them contact information, and voila, you would create something similar to what you're seeing on the screen. One for cancer, one for Parkinson's disease, and you could make actually 16 end-stage indicator benefit flyers. You don't have to. You can buy them for pennies a piece. Just contact TAG, and our contact information is on every screen. However, if you were to start your benefit message, try one or two disease-specific flyers and see how well they work. You'll be surprised. So, shift gears a little bit. Clinicians and physicians recognize that disease or condition-specific plans of care are more effective toward curative outcomes for their patients. It's not just about skilled services. You can draw that picture in non-skilled private duty services as well. So the benefit to a private duty agency would be that it would set you apart from your competition. You're not talking about yourself on every visit. And imagine this. I always tell reps, by the time you finish that 20-second spiel on how you're such a loving and caring and sympathetic agency and they should use you for those reasons, you've already turned that little switch off in the referral source's mind. Because guess what? The 17 people before you that called on them that day said the exact same thing. So it's learned behavior. They think they know what's coming next. So even if you have great benefit, don't lead with the discussion about yourself. Lead with the benefit. It also elevates your staff education and care level. You can make experts. You could have palliative care experts. You could have cardiopulmonary experts in private duty. Give them an hour or 2-hour class. Let your third-party referral sources actually come in and teach them. And elevate your personal care aides, your CNAs, your attendants up to a different level than the competition. If you're going to invest in something, invest in your people. You can never go wrong there, right? Also, marketing outcomes provides opportunity to address disease-specific support groups. If you have created a CHF care package and you're going out and talking to American Heart Association during next February, you have something distinct and different and tangible that they can refer to. They'll become a third-party referral source because you can leave these flyers and talk about how you've gone through the extra training, you've made the patient profiles, you've created this care package that's different than just a sitter service. It also opens up specialty physician markets to your agency. You can do the same thing. You can approach these specialists. You can approach a cardiologist and say, here's what a private duty CHF benefit flyer looks like. Here's what we do, distinct than anyone else. This is the best mousetrap you could choose for the care of your private duty patients in the home. Not only that, I'll prove it to you. I'll make patient scorecards. I'll start back-end reporting whatever you want back-end reported to make our case that we're the better care provider for a specific patient profile. And of course, you can repeat that with orthopedics, post-surgical patients, dialysis patients, women's centers, you name it. It also promotes third-party referral relationships. Once you have gone out into the community and people know of your specialized private care services, when asked about a certain patient profile, you're the top-of-mind agency. because you've made your case on a specific patient population, and you have distinguished your agency that way. So I always tell everyone, before you make any type of specialty program or just show up with an idea. But it's better to let your third-party referral sources, your clinical referral sources, and this goes to hospice, home health skilled, and private duty, let them have input. I always say let them put their foot in your program, because as soon as they do, remember, they're care providers also, it becomes their program. If you bring in a hospice agency to teach your care providers about the special needs of end-stage palliative care patients, do you think they're going to refer to someone they haven't taught those classes to? You allow your referral sources to have input in your operations and get their seal of approval. They'll become advocates, and in some cases, mini marketers for you. So now let's put together a private duty disease or condition-specific care plan flyer like we did for hospice. The great thing is that these are things that we're already doing. We're just drawing out the benefit. We're making our case on a flyer by putting in one or two significant things that we know a certain patient profile would need. So we just need to draw that benefit that we know we can do out and make it tangible to our referral sources. So we can start with arthritis. And if you ever come to a boot camp, I always call this my Myrtle slide. There's a story behind how I made this arthritis package. You're welcome to come. Marketing patient outcomes for arthritis. Remember, if we're trying to sell to a specialist or in a clinical environment, we're going to say, here's our discovery, here's what we did about it, but here's the benefit. You always want to draw out that benefit. And don't assume that the benefit is going to be understood. Go ahead and draw it out so there's no confusion at all. So with the arthritis package, we're going to assist with housekeeping benefit to provide pain and prevent pain and provide safety. We can apply scheduled ice or heat packs to relieve discomfort. We can assist with proper transferring to prevent further joint damage. So if you are a private duty provider and all you're doing is listing your services without drawing the end benefit, you're missing the boat. We can prepare meals to maintain correct diet and avoid discomfort. We can assist with sewing and writing to provide fine motor skill support. That's a unique service that we can, the client, the private duty client can actually dictate. We'll write a letter we'll put it in their care plan. Every day we'll write a letter to a friend or neighbor. We can assist with laundry to avoid lifting and prevent joint distress. When I tell the story of why this is my Myrtle package, that was the epiphany I had, is when I was with a cantankerous patient or client back in the laundry room, and I saw dry cleaning bags all over the place, and then it dawned on me, not only did this lady have COPD, she had so much arthritis that she couldn't lift heavy clothes out of a washing machine. Therefore, she was driving up her household budget by having to send out towels and washcloths and sheets and pillowcases to the dry cleaners when my staff could have done that easily for her. I just needed to get more of a patient profile and make my specialty care packages appropriately. So you do all that, and then you can create the disease-specific private duty arthritis flyer, where you're drawing out specific benefits to a specific patient profile or disease-specific patient. So now we're going to switch gears again. Home health, skilled nursing, and therapy services. Listen, guys, I could talk for 2 hours to this group about marketing outcomes. In fact, this is going to lead into the final webinar of the season in community-based transition programs. There is such an opportunity to set yourself apart from your competitors in every market as a skilled nursing and therapy provider that it's silly that people don't take advantage of it. So if you aren't already going to referral sources on disease-specific sales calls, you're missing the boat. In skilled nursing and therapy, you'll never show up and come up with the right words to say to get the whole pie. They're not going to give you every one of their patients. What you have to do is you have to create a tangible reason why they should give you a slice of pie, that one disease-specific patient profile, and make your case, build your pie one slice at a time with these major referral sectors. Being able to show up to your clinical referral source on specific benefit sales calls will certainly allow you to take those calls to a deeper level with referral sources. If you immediately say on initial benefit, I can reduce or prevent the readmission of pneumonia patients back through your emergency room by 50%, and here's how I can do it. You give me an hour to explain it. I don't care who you get in the room. I'll show you the better mousetrap. I'll show you how it can be done. That opposed to coming and asking them about Dancing with the Stars last night, bringing them donuts, and telling them to remember you on the way out. That's two diametrically opposed sales approaches. And I will tell you that the former works a lot better than the latter. So, in early 2012, the Centers for Medicare and Medicaid Services, CMS, will begin to display new quality measures for nursing homes. Now, this is one of the targeted referral sources that we're going to draw the benefit message to. This is how we're going to reach this one sector of our market with outcomes. So, right now, nursing homes, skilled nursing with short-term residents, ton of business there if we were to approach it. Trouble is, we see them as competitors. They see us as competitors. We've never had that continuation of care model that Medicare always hoped we'd have as home care providers. But we can start building that. And next year, I want you to commit to doing that with this one sector, the nursing homes, because they can't hide behind these star ratings anymore. They're going to be, and this is straight off the Medicare.gov website, by the way. First quarter of 2012, nursing home back-end reporting is not going to be on stars. It's going to be percentage. Therefore, they can't hide the fact, and here's some actual data that's straight off Medicare.gov. These are 3 skilled nursing facilities in Chicago market. This pertains to their pressure ulcer outcomes. The national average is 12%, and that is the amount of pressure ulcers developed between the 5-day assessment and the 14-day assessment. And if you know anything about short-term stays in nursing homes, there is an opportunity there to educate. Also, there's a profitability model that usually ends on day 20. There's a ton of things you should know about this one sector. And if you learn it and if you approach them in the right manner, you could get a continuation of care model set up where they're planning on discharging to home health upon admission, just like the hospital model is today. So if we were to call on Grove, Lincoln, or Schwab Rehab, or St. Joe Hospital, this is Medicare patients only. The back-end reporting on outcomes for these nursing homes is there uploaded for everyone to see on Medicare Compare. Nursing homes, you can put in your local community. If you're in Chicago and you're on this webinar, why wouldn't you be at Schwab Rehab Center Skilled Nursing Unit tomorrow with some assistance on their big problem of 57% of their residents developing pressure ulcers between their day 5 assessment and day 14 assessment. It just makes sense. This is their greatest need, and we should become a care partner with them. This is not dated material. This is, it clearly says, and say what you will about Secretary Sebelius, the chief of CMS and Medicare, Department of Health and Human Resources. She's done exactly what she set out to do to this point. I congratulate her. She's opened up, she's pulled the scab off of a lot of problems within the payment system of Medicare. And now we're going to be redirected on being reimbursed by outcome-driven data, not by how well we can bake cookies and deliver them to referral sources. So just know this data is up to date. It's from October 1st, 2009 through September 30th, 2010, and this is actual numbers that they've reported. So what you would do is you would match up your clinical outcome score. So this is a Quality Chicago home health agency. This is some of their outcome scores. And again, there is no secret as to why all of our wound care outcomes being reported have to do with pressure ulcers. We're being led to the problem. If we're a quality provider for the assessment and treatment and prevention of pressure ulcers, then we should pair up with those people in our market who have the greatest need. It makes sense, right? There's where Medicare and CMS is leading us. So you could develop a pressure ulcer program. The great thing is you don't even have to do that. We've already done that too, and we'll talk about that in a little bit. But you could go and approach skilled nursing facility with the offer of, allow me to become a value-added care partner with you by showing you how to make an outcome-based quality initiative, showing you how we can improve these pressure ulcer scores. And I'll even lay out these 8 ways in which we'll do it. We'll take it on 8 months. We'll do an 8-month program, and we'll do everything from risk assessment, skin assessment and inspection techniques, nutritional assessment, preventative skin care, proper positioning, use of supportive surfaces, accurate documentation, and education to patients and their caregivers at the point where you may be discharging them to home or to another side of your facility. We'll do all those things for you. And by doing that, we'll create an outcome-based quality initiative. So if you were Schwab Rehab Center, it's not a question on if Medicare is going to come knocking at your door and beat you up about pressure ulcers. Everybody on this call should know it's just a matter of when they do that and when you're going to have to pay the fines and when you're going to be subject to severe penalties. And not only that, there's severe liability involved in these because Medicare is now posting civil penalties and fines and incidents on the reporting structure too. If I were a attorney in Chicago and I knew enough about Medicare.gov to look up every nursing home pressure ulcer scores, I would be calling all deceased family member of these nursing homes and saying, guess what? You think we can get a physician to write off the fact that a secondary cause of death may be pressure ulcer infection or skin care, lack of skin care? Imagine the checks these skilled nursing facilities will have to write if that were to happen. Now, that's a pretty apocalyptic view of what could happen. But if you've ever had to testify in court to a clinical matter, it's very hard to defend lack of prevention. So, if you were to pitch a pressure ulcer program, you could do, our agency wants to provide specific training and outside support every month. So specific risk element education, we'll bring in guest speakers and experts. Certainly we're not the experts in everything. We're just the experts in post-acute home care. When it gets to that point, we're the experts. However, if you want a nutritional expert, we'll bring somebody in from Abbott Industries, and we'll talk about the supplements that these high-risk patients should have. If you want to talk about assessment, we'll bring in a certified wound care nurse or PA, nurse practitioner, physician, whoever, to go over the Braden scale and explain to you how keeping someone with a Braden score of 12 or less is like a time bomb. In essence, you can't prevent a pressure ulcer. Their mobility is limited, and they have all the risk factors. It's just a matter of when it develops. So we can assist you in forming an outcome-based quality initiative plan of correction. Because guess what? If you don't take us up on our offer and join us in educating your staff, when Medicare shows up, you're going to have to do it anyway. And you're going to have to start at go, and you're going to have to start on what Medicare wants you to do. However, if you've shown that you did a proactive outcome-based quality initiative, and you reached out of your specialty and reached out to someone who is a quality care provider, that will go a long way in the penalty that will be prescribed to your agency or your facility. So additional services may also be provided through our wound care specialty program. If you have a wound care specialty program, you can reach out to them. You can even do chart audits. You just can't add anything of benefit if you plan on getting the referrals. You want to be careful you don't induce for referrals. So that's one sector. Let's talk about physicians. Physicians in general, they're the most data-driven, results-based, clinical trial-hungry professionals in the world. I'll tell every sales rep that I have contact with, it's a lot easier to get 10 patients from a physician than it is to get one. Because if you approach them in such a way that I will do a clinical trial, you give me these 10 patients and I'll outperform your current outcomes with them through my mousetrap, through my specialized care plan, you've got their attention. So ask for 10 or 20 patients if you've made your case, as opposed to one and then publish a white paper or results paper at the end. Physicians eat that up. It's how I got into marketing. I brought on 10, 20 at a time from orthopedic physicians who I promised to do a clinical trial for results. You'll see a true difference in how you're perceived once you start making your agency's case for their patients with data or outcomes. So this is hospitals. This is an actual hospital, actual results, straight off Medicare, actual presentation. So you see the rate of readmissions for heart failure patients. These cardiopulmonary patients is a big emphasis on prevention and readmission. You can go on Medicare.gov and look up and actually do the data on how many patients they discharged and what their readmission rates are. And listen, give up that false sense of this is outdated data that's up there. It's not. This data was updated October 16th of this year. In fact, Secretary Sebelius is updating this data and your data and the hospital data and the nursing home data every 4 months. It's constantly changing. This is and they'll show you the time frame in which these 1,118 patients were discharged. Usually it's January 1st to December 31st through January 1st, 2010 through January 1st, 2011. But with the specific numbers now comes a specific time in which this data was collected, and you can look that up. But it doesn't take rocket science. All you have to do is take 1,118 patients and multiply it by 0.284, and I'll do that right here for you. And you're talking about a patient population of 317 patients that were readmitted within 30 days to this one hospital. The average loss for a CHF readmission is in the neighborhood of $3,000 to $4,000. All penalties, reimbursements accepted. Hospitals are losing money on these readmitted patients. Now suppose, and they did, St. Franciscan, St. James had their own home health. What would be your argument if they were to say, we have our own home health, why do we need you to come in and be a home health provider? You simply say, Mr. Administrator of St. Franciscan St. James, you're sacrificing $3,500 in losses for that $500 in profit for your HERG score on the home health patient case. I can take that 28.4 and cut it in half for you. I will save you hundreds of thousands, if not millions of dollars a year just on this patient profile alone. That's your case. Why would they sacrifice making $500 when they're going to lose $3,500 on the clinical acute side? So here's their payment back, the median Medicare payment back based on these Medicare specific patients, and all these are direct Medicare, no Advantage care plans are loaded up there. But see, I put on the Medicare payment and volume data. The median Medicare payment back to the hospital, those numbers are from October 2009 to September 2010. That's a one-year block, fairly recent. This is their reimbursement back. And you can bring up the fact that the average CHF readmission costs $13,000 to take care of. Their reimbursement from Medicare is not covering near the cost it takes to take care of these patients. And that's before value-based purchasing comes on the scene. They're going to get a penalty anyway. See, on this, they're not going to get this much money because if they're going to be reduced in their reimbursement for readmissions starting in October 1st of 2012, a static amount. If it's flat rate, if it's a readmission of this certain diagnosis, you're getting cut, your payment's getting cut a certain amount. If you don't have a quality initiative set in place where you're working on your scores, the cut's going to be more severe. If you are written in red on your reporting and you're in the lower 25% quartile in your territory and you're on the CMS identified bad boys list, and I can send you to those lists too in your local hospitals, then your penalty is going to be even more severe. So don't even count on this much money coming to you starting next year. And by the way, the new cutbacks, the new failure in the commission, all these set in place penalties that are going in effect, one of them is value-based purchasing. This is a model of value-based purchasing where hospitals get paid back by Medicare. The proposed fiscal year in 2014, which happens on October 1st of 2013, instead of getting a static 70% process of care reimbursement, it goes down to 20%. A full half of what they would get now, which is, by the way, not even covering it now, would be divided up between outcomes, which is the third line item, and efficiencies, which is the fourth line item. And most of these measure counts have to do with readmissions. Readmissions back into the hospital of certain DRG, diagnosis-specific disease-related groups, which is how they make their money on process of care. So if they have a high readmission rate, 30% of their weighted reimbursement is going to be affected. And then all of you guys that pay taxes will appreciate this. The fourth item, efficiencies, that means your clinician to patient ratios. Simply put, that means hospitals can no longer afford to pay the leaders of their hospital, these administrators and presidents and chairman of the boards, all these enormous salaries. They're going to have to take the reimbursement from Medicare and increase and have a substantial greater clinician to patient ratio than they currently have. Otherwise, 1 in 5 of their Medicare dollars is at risk. So this is the new program that's not even happened yet. So do you think that hospitals want cookies? Do you think they want you to bring them a fruit basket or show up with a bunch of school-aged children and sing carols as a home care provider? Seriously, they need somebody who's going to reduce those readmissions and improve their outcomes, and you need to make their case. You need to put all that together and hit the hospitals with it and show them how you have a better mousetrap. You start off by showing them a little bit about what you're doing now, your clinical outcome scores, your outcomes. You don't have to start here, but it's a good place. If you have these type of clinical outcome scores where you outperform the national and state averages, why wouldn't that be on every brochure you published in 2012? Because it's that important, right? You can make your case on how well your clinicians take care of the patients in the home versus your competitors. You don't have to rely on Medicare.gov alone. You can get some great up-to-date reporting data from other places. OCS, the Home Care Elite scores just published last month. Congratulations, we have some great clients out there. I hope I've sent every one of you a congratulatory email. If I haven't send me an email and tell me I left you off, and I'll send you out an email and one of our sales books or something. But I love it when you guys make the Elite 100 or the Elite 500, and you show yourself to be quality care providers. But there's other reports you can get besides Medicare.gov. And this is valuable information too. Through our CRM service or independent of that, you can reach out to, and I can put you in touch with Health Market Science or the Chesney Group, and you can get some collateral information. It's pretty up to date about different referral sources. And this is how you would decide which specialty program you're going after. You want to fish in the mud hole that has the fish in it, right? Because you can't see the mud hole and tell how many fish are in it. You need that discharge by disease-related group information, and we can lead you in that direction to get it. So when you're marketing outcomes, again, if you're marketing to a hospital administrator, we'll say it's Dr. White, then you want to make your case in discovery, action, and outcome mode, right? Dr. White, this is a presentation. This is a PowerPoint presentation that we're doing, and we're putting it out there that we have the better mousetrap. We can reduce these hospital readmissions distinctively, and here's why. We know a certain patient population are readmitted within the first 24 to 48 hours because home health agencies do a pretty poor job in making themselves known as the experts in the post-acute managed care model in the home. In other words, we leave the patient with no other alternative than to go back to the ER for assistance because we haven't branded ourselves as the care providers. But what we want to do, Dr. White, is we want to put procedures in place where the discharge planners notify us of qualifying admissions, and we give them a brochure with our contact information on it, and we're going to make contact in the home to their other family members or care providers in the home or to the patient themselves, and we're going to tell them a simple message. Your acute episode is over, your managed care episode has begun, and we're in charge of your managed care episode. We will be the fortayers of truth and information of your post-acute CHF discharge. It may be that you need to go back to your general practitioner, or you may need to go back to your cardiologist, but only in certain situations would you ever consider going back to the hospital. And Dr. White, by doing that, here's your benefit. By doing that, we expect to reduce the admissions coming back to the hospital within the first 48 hours. We're going to cut that in half by taking the role of the patient's condition support expert in a timely manner. And you can keep it going. You can say we know a good percentage of patients return to acute care settings because of noncompliance with treatments and meds. What we do is we go out of our way. Here's our script, Dr. White. Look it over. This is written on a 9th grade level. We draw out every medication related to the primary diagnosis, related to all the secondary diagnoses. We not only tell them why and how they should take their medicine, but we also lay out the consequences of noncompliance. We'll tell a patient that they have a better chance of survival joining the Ugandan army in Africa than they do being a second admission for CHF back into an acute care setting, which is true, by the way. And by doing that, Dr. White, we expect to reduce the readmissions back to the hospital by 50% with patients fully understanding their medications, treatments, and complications. So you can go through 5 to 6 reasons. And what you're doing is you're stomping out the little fires before the big fire emerges. And to be quite honest with you, I come from a background in skilled nursing. That's what we do anyway. We're experts in putting out the small fires. We just need to draw the picture, start marketing our ability to establish our agency as being the unique provider that recognizes all these reasons why patients come back into acute care settings, and we do something about it proactively. And as a result, here's your expected outcome. Overall, we're going to take that 27.4% and we're going to cut it to 13.8. We're going to cut it in half for you. So, included in all the other changes to Medicare, which kind of cloud the issues around us. You know, it fills our head full of smoke. The billing grouping, the face-to-face, everything. There is a new emphasis on outcome-based quality initiatives and improvement. This is an effort on Medicare's part for home health agencies to report and be held accountable for their patient quality outcomes. What I'm telling you is, it's not new to us. We've been doing it a while. If you're not familiar with it, I guarantee you someone in your agency is, because we've had to do corrective action reporting back on Medicare audits. I guarantee you have. So in doing that, we've come to know how to make these OBQI. So we do it for our reported 22 outcomes. More and more quality outcomes are going to follow. Again, they're trying to team us up and make us, you know, now we have an outcome, prevention in CHF patients, education of CHF patients as a specific outcome. What do you think Medicare's trying to get us to do? You know, they're doing everything but gassing up the car and stopping by the agency and putting us in the passenger seat and taking us to the hospital, right? Same thing with these pressure ulcer scores. They want us to enter the world of residential care facilities and long-term care facilities. So it now becomes a responsibility of home care to make our own plan of actions. I am telling you, you can reach out into the marketplace and create OBQI for your referral sources. And if not immediately welcomed, when you paint the full picture and they have some exposure in the upcoming penalties and problems, you will be welcomed, I promise you. Medicare is concentrating on the money-saving quality of care issues, so you need to know about OBQI sooner or later. Embrace the opportunity now is what I'm telling you. Start out the new year with, this is my mantra. I'm going to not only be a quality care provider, I'm going to reach out my local service community, and I'm going to bring in all my referral sources and help them be quality care providers as well. And I can do it. And how I do it is on the Medicare model. If you take them through these 9 steps of suggested, and these are listed on Medicare CMS.gov site, collecting the data, measuring patient outcomes, interpreting outcome reports. So you just translate this model that Medicare so concisely gave us, and you assist your referral sources in the same way. And that goes back to the pressure ulcer model that we were going to provide to the skilled nursing facility who had really horrible development of pressure ulcer scores. So we help them develop their action plan, implement their plan, and then monitor it on an annual basis. You won't have to make sales calls to these referral sources anymore. It'll all be purpose calls. I tell all sales reps, if you want to quit making sales calls, then add enough benefit that you're just coming in to discuss the new benefit that you're adding to their world. But if we are so stubborn that only talking points we can make is how great we are and how much compassion we have for the elderly, when a lot of administrators of skilled nursing facilities have sleepless nights worried about 1 or 2 patients that are in their facility, and you're trying to make a compassion sale to this person, it's not going to work. Try helping them out. And then when you do, publish it. Publish how your outcomes are superior, not only your competition, but how you were part of an outcome-based quality initiative with one of your referral sources and you brought their scores down or up, as the case may be. So let the world know it. It's very effective. If you were to hand a physician, and this is an actual patient outcome flyer, if you could hand a physician this tangible data, you would be as opposed to a dozen donuts. And granted, a dozen donuts right now cost about $5.50, and this flyer costs about 48 cents. Which one do you think would go further? So, we have 6 specific PowerPoint presentations that you can start with. I don't tell you that it's exactly the care plan that your clinical side is going to embrace and develop and you can hit the market with it tomorrow. What I'm telling you is it's 100% complete. However, you'll need to modify it to tell your story and what your clinicians are trained on and what they're prepared to do. However, we have 6 of these PowerPoint presentations that are open templates. We modify them to your specific agency with your logo, all the information on it, and we've chosen these 6 for obvious reasons. The first 3 are based primarily to go out to hospital settings and make your case on 3 distinct patient profiles. The first one being CHF, post-heart attack. Second one, increasing diabetic patient outcomes and reducing readmissions to acute care. Now just read the title of these PowerPoint presentations and tell me that the hospital wouldn't be interested in looking at your presentation. I can't tell you, when I first came to TAG, I was just shocked at the amount of PowerPoints we put together for some of our clients, and all it did was tell their story, right? Now, they took on a charity case in 1997, and they bought this lady a new trailer or a new car or a new handicap ramp or whatever, and how great they were for doing that. How much play is that going to get? In a referral source environment, remember, they're just as compelling, they have just as compelling a story and just as compassionate as we are. If you're talking about yourself when you're doing a PowerPoint presentation, save the time, just leave the lunch, and make a graceful exit, because you can, spend your day doing something else, because you're not going to be very effective. Increasing COPD outcomes through patient care, self-care initiatives. The emphasis in these PowerPoints is not blaming the hospital for post-acute readmissions, and not really blaming ourselves for post-acute readmission, but putting the responsibility back on the patient and family through education and steps that they should take in best practice to avoid readmissions. Now here's some more, and here's a good story of how you can go not just at the hospital with outcome-based quality initiatives, because most of us are pretty fluent that they need cardiopulmonary assistance for readmissions, but you can also go in residential care with these 3, and there's reasons why these 3 exist. Pressure ulcer prevention and care continuum. Step 1, you are reporting percentage of pressure ulcer development. Step 2 is penalizing on pressure ulcer development. But hidden in that is, if Medicare don't kill you, the litigation attorneys will on pressure ulcers. And if you're not currently on cable TV getting commercials from litigation attorneys talking about pressure ulcers in residential care facilities, you're lucky, because they're saturated the entire country. This is a big problem. You're coming with a proposed solution, nothing else. You can make your case as to why they should drop off these patients with a score of 12 or less on a Braden score, assessment score, to home health where there is no liability, would be one of your messages. If someone scores on your initial 5-day assessment a Braden score of 12 or less, you need to pick up the phone, give home health a call. Here's our pressure ulcer prevention and treatment scores, but you are going to put your facility at risk for major liability. Dementia and abuse training for facilities, that's one of the new mandated training that long-term care and skilled nursing facilities, residential housing facilities have to do starting in past October. It's already enacted. You could take, and that's a presentation on how you'll come in as a care continuum provider and provide that training outsourced, one training session a month, and you'll document it, and by doing so, you'll provide them case evidence of the training occurred, and we didn't do it in-house. We have documentation that was provided by another care provider. It goes a long way with Medicare. And a community-based fall prevention program for older adults is the #1 reason of acute admissions in residential care. If you're thinking that they're not going to be attacked for their prevention of fall measures and procedures by Medicare, when it's the single primary cause of acute readmissions from residential care to acute settings, then you're crazy, because that's what's coming, right? So that's why you have these 6 classes: increasing cardiac outcomes through patient self-care initiatives, increasing diabetic outcomes and reducing readmissions to acute care, and increasing COPD outcomes through patient self-care initiatives. I know COPD is coming because they're already posting the numbers, the reporting of Medicare payment numbers to hospitals. One of them is COPD. And then in other settings, and you can reach out to ALS as well, but long-term care needs this, but you're wanting to get skilled nursing facilities that have short-term beds. I'll tell you how to profile those and go out with the pressure ulcer prevention and care continuum. It's a very powerful presentation. So we'll send you out. They look like this. However, we'll put Miranda and her team. I'll give you a little bit of window into some design that will put your agency colors and logo on there for you before we send them out. You'll get 6 PowerPoint presentations customized, each one lasting anywhere from 35 minutes to 55 minutes in a presentation. It's very fleshed out. However, if you wanted to use this as 80% of what your presentation is going to be and add, subtract, multiply, do whatever, you'll have the master screens to do it. All you'll need to do is add content, take away content. You can customize it to tell your message fairly easy, and you'll hit the ground running in 2012. There'll be no excuse as to why you can't do it. All you have to do is clear it through your clinical director of clinical services and your field nurses. Here's the way we're going to present this, so let's make sure that we can do it, and you'll be off and running. Or if a single presentation has caught your eye, all you have to do is call in, and you can get a single presentation for $497, and you get the same logo. We'll put in your logo and change the coloration of the presentation for you. They're very powerful. I've done them. We have clients that we go and do presentations, PowerPoint presentations. You automatically, going in with a PowerPoint presentation, you're going to be head and shoulders above everybody else that has brochures and is feeding people pizza and is trying to talk over the chatter in the room. It's more pointed. It'll get your point across. Plus, I don't want you to publish a lot of stuff and give them great ideas. I want you to be part of the package. The close in all these presentations is we want to be the preferred care provider for this one patient profile population. We want to be the COPD patient provider. Give us 20 patients. We'll publish a white paper and show you how this better mousetrap that's laid out in this PowerPoint presentation can reduce your readmissions by 50%. So it's a very powerful presentation. So get on the coaching call. I would love to talk to you about how we've helped companies start an initial grant proposal, if that's the direction you want to head in. So here's all the contact information. For me, again, this was to offer today. You know we have a lot of other stuff, but this stuff right here, this is magic. If you call in to one of the tag team members and say, we want these proposals, then you're going to lock out every competitor in your market. These are market specifics, and there's some markets that we can't already sell to because they've already been purchased. But there's about 73 markets still out there. And even if you don't want to do anything with these presentations, you better buy them up so your competitors don't have them and make a care transition program out of them. That's the word to the wise. When you call in and a tag team member says it's no longer available, I apologize. But we're not duplicating these presentations. We're making them market specific. And honestly, because of that, we should be charging probably 5 times more, but we don't. So this is how you contact me. If you want a coaching call about anything we talked about here on the Outcome-Based Quality Initiative webinar, you can reach me at eric.crump@theadamgrp.com, or simply call in 1-866-232-6477. One of the tag team members can schedule you a coaching call. You can have your clinicians on it. You can put it on speakerphone. I'll take all these OBQI coaching calls and the care transition coaching calls And I've got, as you can imagine, even putting together this webinar, I got a lot of information. I could easily email you links to government sites, information on best practices and all kinds of things. So, or you can go online and go to www.homecarecoachingcall.com. So I'm going to answer some questions now for all you brave souls who made it to the very end, and I appreciate it. And we love you for it. We try to add value to all these webinars to the point where even if you don't learn anything new, you're reminded of things that you thought about having. So if you have a question, put it up there now. I'm going to spend about 3 minutes answering questions. First question is probably early on, but it's what does OBQI stand for again? It's Outcome-Based Quality Initiatives. And it's not just home health that has to do it. It's other areas too. Eric, where are the templates for the hospice and private duty? They're talking about the benefit flyer. A little known fact, all you hospice guys that still may be on the phone through that tirade I made through Home Health Services. If you were to buy that $97 book, that template has all those flyers that I just showed you. The template for that. So Power Plays for $97 gives you the template to all those benefit flyers, along with about 30 more. Yeah, the value in the CD surpasses the value in all the information, and it's some pretty good information. We always get, will you send the PowerPoints out today? Yeah, most of you, if you don't already know, Nick Bastano, he's a moly-looking guy. He looks like he dug out of a hole somewhere, but he's really intelligent and he's really thorough, and he sends out the post-webinar emails with the attachments to the slides and everything. And also, you can go to, I'm just kidding, Nick's adorable. We all know Nick's adorable. You can also go to www.youtube.com/tag webinars, and you'll see after the care transition webinar next week, this whole season's webinars will be uploaded on YouTube. And you can see past seasons webinars on YouTube. I only caution you, some of them are dated because, you know, our industry changes. We try to stay on top of it. We update all of our presentations. Have a question about private duty that's sent. The templates. Yeah, I'll send you a sample template if you email me at eric.crump@theatomgroup.com. Private duty specific in targeting marketing works and private duty services. Don't get me on a tangent about productivity models, but if we don't give our direction of our sales staff, if they don't have an overall theme and way to go out and reach the market with our talking points, then it's our fault that our money is wasted on donuts and bagels and Santa Claus plush with jelly beans in their belly. And can you tell me more about the community-based transition programs? Sure. That'll be next Thursday on December 15th, and the Presenting Care Transition Programs to Supercharge Referrals. If you haven't already signed up for that webinar, make sure you do. It's pretty powerful. We'll talk about how you present a mousetrap to the hospital, convince them that you're the better care provider, that you're going to be a problem solver for them, and how to enter with us as a team. Now let's get government funding, because Medicare has gone above and beyond making monies available to us. And as much whining and moaning that we do about the cutbacks in Medicare reimbursement, the same amount of money that they cut back from all of us is sitting over there in another pot for preventive care services. Now, are we going over there to get our money back by creating these community-based organizations, or are we just going to let it sit over there until Advantage Care Plans take it? That's the question to be answered. So, as you can tell, next week's going to be a pretty opinionated presentation as well. Guys, I got some thank yous on here, and I want to share the love. I do appreciate what you do on a day in, day out basis, and if we can add a small component and help you be more successful, that's what we're here for. I'm going to leave my contact information up a little while longer. Feel free to contact me about any of the topics I either went into detail or mentioned on today's webinar, and I hope you guys have a glorious day. Thank you. Goodbye.